Welcome back, everyone. Today, we are diving into a topic that literally holds us together, but in a very specific, mechanical way. We're talking about retinacula and how they manage our tendons. Dr. Sarah, I'm pumped for this because to me, this is the engineering of the human body.
It really is, Dr. Khan. While many students gloss over fascia to get to the glamour organs, the boards love the specifics of deep fascia, specifically the retinacula. For our listeners, remember that these are not just random pieces of tissue. They are specialized thickenings of the deep fascia that act as restraining bands.
Right. I always tell my students to imagine a high-tech fishing rod. If you didn't have those little metal loops, the eyelets along the rod, and you hooked a big fish, the line would just snap straight from the tip to the reel. That's called bowstringing. In the body, the retinacula are those eyelets. They keep the fishing line, our tendons, snug against the bone.
That's a perfect clinical analogy. From a high-yield perspective, you need to distinguish between superficial fascia and deep fascia. Superficial fascia is that loose areolar and adipose tissue, your subcutaneous layer. But the retinacula are part of the deep fascia. This is a dense, membranous layer that invests muscles. When it thickens at joints like the wrist or ankle, it becomes a retinaculum.
And why does this matter clinically? Well, if you didn't have these restraining bands, your muscles would lose their mechanical advantage. If your flexor tendons popped out away from your wrist every time you made a fist, you wouldn't have the leverage to actually grip anything. You'd have the strength of a wet noodle.
Exactly. And speaking of the wrist, we have to talk about the contents. The boards love to ask what travels deep to these structures. Take the flexor retinaculum at the wrist. It transforms the carpal arch into the carpal tunnel. If you have inflammation of the synovial sheaths under that retinaculum, what happens, Dr. Khan?
Oh, that's the classic carpal tunnel syndrome. Because that retinaculum is so tough and inextensible, it doesn't stretch. So if the stuff inside, the tendons or their sheaths, starts to swell, the pressure has nowhere to go but onto the median nerve. It's like being in a crowded elevator where the walls are made of steel. Someone is going to get squished.
Spot on. Now, let's get precise about those synovial sheaths you mentioned. Students often confuse them with bursae. A bursa is like a flattened, lubricated balloon that reduces friction between a tendon and a bone, but a synovial sheath is a tubular bursa that actually wraps around the tendon. It's like the tendon is sliding through a lubricated sleeve.
I like to think of it as a sleeping bag. The tendon is the person, and the synovial sheath is the sleeping bag, protecting them as they slide around inside the tent of the retinaculum. But there's a catch. The tendon still needs blood, right? It can't just be floating in space.
Correct. That's where the mesotendon comes in. It's a fold of the synovial membrane that carries blood vessels to the tendon. In areas with high mobility, like the fingers, these can become thin threads called vincula. If a surgeon, the patient's doctor of choice for a complex repair, is working on a lacerated tendon, they have to be incredibly careful not to destroy that blood supply, or the tendon won't heal.
That is a huge clinical pearl. No blood, no healing. Now, Dr. Sarah, let's talk about the extensor side. At the wrist, the extensor retinaculum is actually creating little compartments, isn't it? It's not just one big tunnel like the flexor side.
It is. The extensor retinaculum sends fiber septa down to the radius and ulna, creating 6 distinct compartments. For the boards, you often need to know which tendons are in which compartment. For example, de Quervain's tenosynovitis involves the first compartment. This is where the anatomy becomes the diagnosis.
Why does this matter clinically? Because if you are injecting a steroid to calm down that inflammation, you need to know exactly which tunnel you're aiming for. If you miss the compartment, you miss the cure. It's all about the boundaries formed by that deep fascia.
And don't forget the lower limb. We have the superior and inferior extensor retinacula at the ankle. If a patient has drop foot or issues with dorsiflexion, we have to look at whether the tendons are being properly restrained or if there's an entrapment. The principles are the same. The retinaculum is a pulley, and the synovial sheath is the lubricant. I love that. It's simple but vital. If the pulley breaks, the machine fails. If the lubricant dries up or gets infected, like in infectious tenosynovitis, the whole system locks up. You can actually get trigger finger because the tendon gets a nodule that can't slide through the pulley system of the retinaculum. To summarize for our exam takers, retinacula are thickenings of the deep fascia. Their primary job is to prevent bowstringing and maintain mechanical advantage. They often house synovial sheaths, which are tubular bursa containing a mesotendon for blood supply. Clinical issues usually arise from either friction, tenosynovitis, or compression like carpal tunnel.
Beautiful summary. Just remember, folks, fascia isn't just the white stuff you pick away in the cadaver lab. It's the structural harness that makes movement possible. Next time you flex your wrist, thank your retinacula for keeping your tendons in line. See you in the next episode.